Hello, welcome everyone to today's webinar. My name is Billy Brush, your webinar host for IntraOp Medical. Thank you for joining us today for the first webinar in a series that we're going to be hosting. You'll be hearing of future webinars on an array of topics from pancreatic cancer to flash radiotherapy. So we are planning to have one each month throughout the remainder of 2020, so please stay tuned for that. For today's discussion, you're going to be in listen mode only. You will have the opportunity to ask questions in the Q&A chat box. It's at the bottom of your screen, and we encourage you to ask questions at the end of each presentation. Our speakers will make every attempt to address them at the end of the presentation, or we'll have a follow-up afterwards. The webinar will also be made available offline to all of those who have registered. And now I would like to introduce you to the CEO of IntraOp Medical, Derek DeSholi, who will be introducing today's speakers.
Hi, thanks Billy for the introduction. Hello, welcome everyone. I just want to thank you all for attending today's webinar discussing new developments in breast radiotherapy. I also want to especially thank our speakers for taking time from their busy clinic schedules to put together the content for today's discussion. Especially as it's close to the holiday season in Germany. I know that they put really extra efforts in here to put together a really nice program for our 30-minute webinar. And clearly it looks like there's a lot of interest. We have just around 600 total registrants with medical professionals participating from over 50 countries on 6 continents around the world. So that's fantastic, and we're looking forward to an educational webinar today. So without further ado, I'm delighted to introduce to you today's speakers. We have Professor Jürgen Debus and Professor Jörg Heil from University Hospital Heidelberg in Germany. Heidelberg has been a recognized leader in the field of oncology and specifically in the field of IORT for decades. And they've been using the Mobitron technology for IORT since 2013. Today, Professor Debus will be kicking us off. He is the medical director of the Department of Radiation Oncology and Radiation Therapy at Heidelberg University Hospital. He's also the director of the Heidelberg Ion Beam Therapy Center and the Heidelberg Institute of Radiation Oncology. He's the principal investigator of the Cosmopolitan trial for Electron IORT for low-risk breast cancer, and he'll be discussing that trial and single-dose Electron IORT as a method of APBI in today's webinar today. Thanks again, and look forward to having a good webinar with you all.
Dear ladies and gentlemen, it's my great pleasure to present to you today the intraoperative radiotherapy with electrons for the treatment of breast cancer. And I'd like first to thank you all for joining this webinar, and especially also for IntraOp organizing that webinar. The background of treating breast cancer in low risk early stage is that we can achieve nowadays very high cure rates and very high local control with adjuvant whole breast radiotherapy, and typically we expect around 1 to 2% local recurrences. However, whole breast radiotherapy may be associated with considerable morbidity and mortality from other causes, and this restricts also the survival benefit in this group of patients, and has also significant socioeconomic impact on the treatment of our patient. Therefore, a lot of people thought about omitting adjuvant radiotherapy in such scenarios, and here there's a compilation of the different studies who tried basically more than 20 years ago to omit radiotherapy in the adjuvant setting, but it turned out that with a hazard ratio in the mean of around 6.8, there is a high risk of local recurrences, and you cannot just omit radiotherapy, and the number to need to treat of the patients is between 15 and 33 in order to improve survival. So one of the ideas behind that omission was is there a possibility to treat only parts of the breast? Based on analysis of recurrent breast cancer undergoing mastectomy or re-resection, it turned out that the majority of recurrences, around 2/3 of the recurrences, are within 2 centimeters of the original site. And even if you look closely, it's a high risk that the patient recur within that site, and therefore a local therapy seems to be logical. If you look to attempts of using percutaneous partial breast irradiation, as shown on the right side, there are obvious limitations, because in contrast to what you do, for example, with intraoperative radiotherapy, you still are heading with a long treatment time. And this prolonged treatment time has also significant impact on the patient, and nevertheless, targeting is of crucial importance in that area. And as we all know, the omission of parts of the tumor beds by percutaneous radiotherapy is one of the key problems. In contrast, intraoperative radiotherapy, which, for example, we use now for more than 30 years, is the ideal method, because during surgery, you are able to actually precisely locate the area where the tumor has been resected, and even more, you will be able intraoperatively to adapt the target volume to your treatment volume, meaning that you can exactly push the margins of your resection by a suture in an area which exactly fits into your treatment fields. On top of that, we have been for a long period of time wondering why, for example, local results and also results on systemic controls of the tumors after intraoperative radiotherapy, not only for breast cancer, but also for other cancers, are really high. And one of these aspects nowadays is that a couple of groups could identify by collecting surgical wound fluids that intraoperative radiotherapy significantly in controls with cell culture growing in 3D show that the mobility and the invasion of tumor cells is reduced by changing the microenvironment. This means that intraoperative radiotherapy has also a certain systemic effect. Even more, it seems that by radiation-induced damage in the tumor cells, we activate also the immune system, and this causes also bystander effects, leading to further control also of non-irradiated sites. We are currently undergoing studies where we try to identify which parts of the immune systems are activated, and can we, by any means, also intensify these effects in order to have a synergism between intraoperative radiotherapy and immune therapy. The first group who did intraoperative radiotherapy was the Italian group around Veronese. They started their trial close to 20 years ago, and this was a single center phase 2 trial where they randomized 1,300 patients in a non-inferiority trial, comparing intraoperative radiotherapy with 21 gray of electrons with a whole breast irradiation in conventional fractionation plus 10 gray boost. It turned out that the intraoperative radiotherapy had inferior local control. However, if we look closely, the majority of these patients, which have been included here, and we have give credit to the fact but at the time, the selection criteria were not very well known at that time. How can we select patients for intraoperative radiotherapy? And this is due to the fact here in this study that more than 1/4 of the patients who have been node positive, more than 20% have been high grade, even estrogen receptor negative patients, and more than 20% of patients received adjuvant chemotherapy. So obviously not good candidates to be eligible for intraoperative radiotherapy in the current understanding. And nowadays, on retrospective analysis, the group could show that a tumor size of larger than 2 centimeters, nodal positivity, G3 triple negative tumors had all a very high hazard ratio also for local control. In absence of all these negative factors, the 5-year local recurrence rate was 1.5%. So extremely good for this group of patients. So the group did also an analysis later on the retrospective data from the European Institute of Oncology and stratified the patient to the ESTRO criteria, which we just discussed. This results that patients which were suitable, as you see here, 294% patients were suitable, had an extremely low risk of 1.5% of local recurrence and also of distant metastasis, and an excellent overall survival of 98.6%. But even if you look in the cautionary group, so patients who do not completely fulfill this criteria, the local recurrence rate was in the order of 2 to 5%, and the overall survival was 97.5%. So also, let's say in a cautionary group, a group of patients where you might consider such an approach. But even the group which was considered to be unsuitable had a rate here, as you see, a local recurrence rate of 8%. However, we have to say there was no major restriction on the overall survival. So also overall survival was 95%, which can be considered excellent for this group of patients. Regarding overall survival, there is this meta-analysis which appeared in Lancet Oncology 2 years ago, where people compared the different studies results regarding the breast cancer mortality. And as you see, there's no difference in breast cancer mortality if you compare IORT or whole breast radiotherapy. However, there's a trend for overall survival and also a trend for non-breast cancer deaths, which favors intraoperative radiotherapy. So, who are the patients who should be treated with intraoperative radiotherapy? If you look closely, partial breast irradiation should be considered for patients with clearly negative axillary nodes. And if you look closely, the consideration of accelerated partial breast irradiation should be considered in low-risk patients according to the most recent version of the NCCN guidelines. And if we compare now how NCCN guidelines developed, what was the previous version and what is now the most recent version of these guidelines, so patients should be encouraged to participate in clinical trials in order to be able to learn more about the accelerated partial breast irradiations by intraoperative radiotherapy. And according to the guidelines, now also ductal carcinoma in situ, which was formerly not allowed, is now allowed under certain conditions. I cannot go into the detail, but it further progressed and more easily, and it's now visible that you can apply intraoperative radiotherapy now also in our scenarios. The German group, the German Society of Radiation Oncology called DEGRO, has also introduced practical guidelines for practical breast irradiation. And with practical guidelines, they encompass selection criteria, which is typically age over 50 years, invasive carcinoma of any grade or low to intermediate grade DCIS, tumor size smaller than 3 centimeters. It should be a unifocal disease, and it should have a negative resection margin. There should be no vessel invasion, and it should be obviously again node negative. And the other group is the patients group who are on a microscopic level, obviously not on a clinical level, but on a microscopic level, might be even node positive. The challenges for intraoperative radiotherapy is that during the time of surgery, typically the evaluation if the patients have lymph node vessel invasion or extensive intraductal component cannot be fully ruled out because you do not have a pathological report in your hand. Therefore, one of the reasons you should deliver IORT preferably within clinical trials. So far, we can say under the conditions of the trials, this limitation was not clinically relevant so far. How is the target definition? As I already pointed out, the big advantage of intraoperative radiotherapy with electrons is that you are able to adapt your treatment volume intraoperatively so it fits exactly to your target. So the intraoperative radiotherapy is basically directly applied after surgical excision, and you put typically also insertion of protection shield onto the pectoral muscle, and later on Jörg Heil will also demonstrate that in his talk. The target volume should have at least a margin of 20 millimeter in any direction, which typically leads to the fact that the lowest or the smallest tube size is around 5 centimeters. Typically, it's also very important that you completely spare the skin out of the irradiated volume. This leads to better also cosmetic results. One of the aspects of this method is that we can reduce significantly the irradiated volume. It has been shown that with whole brain, with whole breast radiotherapy, the patients have significant fatigue after adjuvant radiotherapy. This is, for example, shown on the single center cohort study, showing that the patient who has radiotherapy, or even the patient who has a combination of chemotherapy and radiation therapy, has significant fatigue during that kind of treatment. Around 40% of patients still experience fatigue even 1 year after this kind of treatment. Fatigue, therefore, has a significant socioeconomic impact. And this is one of the reasons, for example, why a lot of people nowadays think, how can we reduce fatigue in this group of patients? Because fatigue is currently the strongest predictor of diminished employment after radiotherapy. And we know that a quick rehabilitation of the patient into his professional life is not only from the socioeconomic endpoint, but also from the psychological endpoint, a very important issue. What is the impact of this fatigue? As I said, it has a strong socioeconomic impact. And if you look closely now also to the data of this analysis, it has been shown previously that accelerated breast irradiation can significantly reduce this. This is one of the questions we like to investigate in our Cosmopolitan trial, which is running here. The typical trial population are patients who are suitable for intraoperative radiotherapy by all the criteria so typically low-risk patients who are eligible for breast-conserving surgery. The primary endpoint of this study is fatigue after 12 weeks. And in this randomized trial, we'd like to learn to quantitate the effect of the fatigue in comparison between intraoperative and whole breast radiotherapy. And the secondary endpoints are obviously local regional control and also distant tumor control and overall survival, but also secondary malignancy on the long-term run. From our point, a very attractive study also for the patient in order to be able to learn, can we avoid fatigue in this group of patients undergoing intraoperative radiotherapy? These are the inclusion criteria. As I mentioned, typically very strictly the inclusion criteria, which make patients suitable for intraoperative radiotherapy of breast cancer. And we exclude, however, the patients which can be considered high-risk patients by any means, or patients where we would be not able, for example, to exactly determine the secondary endpoint. I hope this study will answer that questions and will also help to promote intraoperative radiotherapy in order to be able to better treat our patients with breast cancer in a shorter time and with a better quality. Thank you for your audience.
Thank you, Professor Debus, for that interesting and enlightening talk.
Yes, you're welcome.
I think we can now open it up to some of the questions Billy can list off that we've had in.
Yeah, it looks like we have 2 or 3 questions here, Professor Davis. The first one is, how would you compare the Elliott trial and Cosmopolitan trial to the target trials?
Okay, so the target trial have been basically using photon IORT, and photon IORT is a completely different approach because you basically treat more the superficial lesions. And as I mentioned already, with the electron, you basically follow a completely different direction, because in a close interaction also with colleagues from surgical oncology like Jörg Heil, you basically adapt your target volume exactly in a way that you can treat it. Whereas, for example, if you use photons, you basically try to have a resection cavity, which is in many of the situations not circular, and you basically try to get in your applicator, so you have to adapt it kindly. So this is one of the aspects. The other aspect is obviously that by the penetration with electrons, you have a clear penetration depending on the energy of the electrons, and you have very homogeneous treatment over your target volume, whereas with the treatment with photons, there is a highly inhomogeneous treatment of this target volume.
Great, thank you. The second question that came in is, do you see patients that are more interested in this in the era of COVID?
Yes, as a matter of fact, this is what you would call a single-stop shopping, because the patients do not have repeatedly visit the radiation department. So especially under the times, let's say, of the pandemic, you may be able to even reduce the contacts of the patients with the hospital by just the stop for surgical resection and the intraoperative radiotherapy, and you avoid all these planning CTs and repeated visits at the conventional accelerators. So especially during the times of COVID, it has 2 advantages. One is reducing the contacts, and at the same time also being able to deliver a highly effective treatment.
Excellent, thank you. And then the last question that I see here for now is, how do you handle a case with positive surgical margins?
Typically, you let's say in a typical scenario, you expect that the positive surgical margins are realized if you receive a pathological report. what is typically done in such a scenario is to consider if it can be reconstructed, that you do a re-resection for this R1 situation, and you try to resect that. If the R1 resection, however, cannot be located, you might consider increasing the dose, but in most of the patient, we did re-resection.
Great.
But nowadays, maybe we have to say it happens really rarely. It was in former times, let's say 10 or 20 years ago, it was a situation we had quite often, meaning something 1 out of 10 patients. Nowadays, R1 resections are really rare.
Okay, thank you. It looks like we have a few more questions coming in.
So there was a question if one is able to apply radiotherapy after re-resection. We typically apply intraoperative radiotherapy, especially after resection, also for recurrent disease of previously treated patients. This is very typical. However, for example, if we already applied intraoperative radiotherapy and we should find, let's say, an R1 situation, we would not apply another intraoperative radiotherapy to that area.
Great, thank you. Do you see the other questions, or would you like me to repeat a couple that I've received?
I see here, can I use a software for treatment planning for IORT? The problem is you can use treatment planning software for IORT. However, you needed the imaging at the time of surgery, and this is of critical importance that you really know if you want to do a treatment planning that you do. Is there are no approaches that you can really do on-site imaging, also with IntraOp and also with a planning tool, so that you can use that planning tool in order to exactly use the anatomy at the time of resection, for example, by a dedicated CT, and then do the treatment planning on that. Typically, the usual treatment planning software will not be able to do that.
Okay, let's see. Are looking to see if there are more questions. It looks like there is.
Probably for time, maybe we should.
Yeah. You're right. Do we have time for one more question, Derek, or do you want?
Okay, yeah, let's do one more.
So I've just seen one question. External radiotherapy may not give sufficient dose to the excited tumor size. No, this is not right. So what we know is that with external beam radiotherapy, we can deliver a sufficient dose to the excised tumor site. However, we know that we treat, let's say, a significant part of normal breast tissue without the necessity that it needs dose or that it needs treatment. And the big advantage of IORT, we can concentrate our dose to the area which is really needed. But from an effectivity, especially if you, for example, if you have a high-risk area and you give an additional boost, you deliver typically sufficient doses also with external beam radiotherapy. It was one of the questions of John Glees here. But the advantage is with IORT to be able to reduce the volume which is needed.
Okay, great. Thank you very much.
Yeah, you're welcome.
So our next speaker is Professor Jörg Heil. Professor Heil is the head of senology unit and an oncoplastic breast surgeon at the University Hospital in Heidelberg. As one of the leading academic centers in Germany, the Heidelberg University treats around 1,200 breast surgeries per year. Professor Heil is also a trained expert in breast imaging and the systemic treatment of breast cancer. His topic will cover practical experiences with surgical procedures before and after IORT.
Dear colleagues, thank you very much for having the possibility to tell you some of my practical experiences with surgery before and after intraoperative radiation therapy. So first of all, I would really like to focus on topics from a surgical point of view, as Professor Debus probably already showed you the radio-oncology aspects. So I would like to focus on these three aspects, which patient to include and why, and I will really focus on the Cosmopolitan cohort of patients. Second, do incision pattern matter? And third, what about intraglandular reconstruction and oncoplastic surgery? Because both things I always hear from my colleagues as a matter of debate when talking about intraoperative radiotherapy. So first of all, which patient to include and why? You must have heard from Professor Debus the inclusion criteria for the Cosmopolitan cohort, what is an early breast cancer cohort of an age above 50 years old with small tumors. But when we see them in our pre-therapeutic tumor boards, there's always some points we discuss. Should we really include every tumor in every position? And I would say yes. And the other aspect is, could we include all breast densities, sizes, and ptosis? What really matters for surgical planning? I would also say yes. And some debate exists about the question if tumor is close to the skin or the pectoralis muscle. And if you think about that, also when you have the radiation done percutaneously, you don't think of these aspects. So I would also think that an intraoperative approach is possible also in these cases. And I would like to illustrate this for you on an example. So for example, you have this breast here, and the tumor lays in the upper outer quadrant, and it is very near the skin. So some colleagues always argue that you cannot do intraoperative radiation therapy because the region of interest you want to radiate is not easily accessible. That is true and not true. What is the reason of interest? The reason of interest is the surrounding breast tissue, not the subcutaneous fat. Of course, we all know that the breast tissue is within this fat, but very minimal. So I would say, yes, you can, because you could resect this by a radial incision pattern, perhaps taking some skin, and then you can, of course, take this tissue and put it together here, and then radiate with a tube here. So this must be as efficient as if you do it percutaneously. So that is only one example why I think you really can include every tumor position and in every tumor quadrant, breast quadrant, so there shouldn't be a problem. Do incision pattern matter? And this is perhaps a little bit difficult to clearly answer, because on the one hand, it is important because you should place the tube on top of the region of interest. You can't tunnel through the whole breast like you sometimes do within breast surgery. On the other side, I would tell you that nearly every tumor position, tumor size in relation to breast can be approached differently. So there's no problem to have a somehow include this intraoperative approach. And this I can also show you by an example. For example, if you have a breast like this, and the tumor is here, you can, of course, do an incision from the intramammary fold, or you can do a periareolar mastopexia, or you can do an incision here, an incision here. 4 incision patterns possible for this tumor position. You could also do an inverted T when you do an oncoplastic surgery. So, and now if you think, okay, this is a patient, I can do intraoperative radiotherapy, you can of course not come from an only inframammary fold incision, because then you need to tunnel above. If you do it very large, you could probably elevate the skin and also do it from this incision. But then you could also do this periareolar approach by deepithelializing this skin, or you do a vertical T incision pattern, what also can then have a positive impact on breast shape. Of course, then you discuss with the patient a contralateral symmetrization. So this is an example showing you that for one possible tumor position and tumor size, you can always try to find an incision pattern, what on the one hand is possible for an intraoperative radiation therapy, and on the other hand is beneficial for the patient and the aesthetic outcome in the end. This is one example when you have pictures from an intraoperative situs. So first of all, you resect the skin. This is an incision pattern at the periphery of the breast. So you incise the skin here, and then you resect the tumor was here. And then you mobilize the breast tissue, all this here, and put it within this hole where the tumor was. In the end, you close this defect by an intraglandular rotation flaps. So you have the region of interest exactly where you want to have it for reconstructive purposes, but also when you place here the tube, this is very good for effective radiation therapy. Third, and this is nowadays very important, what about oncoplastic surgery? Is it competitive, or is it perhaps one possibility to increase the effectiveness of oncoplastic surgery? And I would say intraoperative radiation therapy is based on clear resection and intraglandular rotation to have the region of interest, the region you want to radiate. And this forces the surgeon to really do good oncoplastic surgery to make intraoperative radiation therapy possible and effective. So from this point of view, I think intraoperative radiation therapy and oncoplastic surgery comes very close together. And you can see it here in a picture of my colleague Werner Audretsch, published in 2014. Well, there's only one possibility, one example how you can do that. This is a tumor in the lower part of the breast, an apoptotic breast. and you can resect quite a lot of skin, a lot of breast tissue, then rotate dermoglandular tissue and have a very good positioning of the radiation tube, and you have a very effective and less morbidity for the patient in this case. You also can use larger volumes of the tube. So this is a very good example how you can do. I would like to stress that in the Cosmopolitan cohort, please be aware of that this is a cohort of small tumors, older ages. I don't think that large oncoplastic approaches like the reduction mammoplasty or others is very uncommon. So it is mainly a question of how to resect and then do small volume tissue replacements for intraoperative radiation and a very good aesthetic outcome in the end. To summarize, I think intraoperative radiation does influence the surgical approach. I've shown you some examples in the last couple of minutes. But I think in the majority of patients, it is a benefit for the patient, not only because she only have the radiation in the surgery, but also for aesthetic reasons. You need to know that intraoperative radiation therapy prolongs the surgery relevantly. I don't have the exact minutes in mind, but I think a normal breast conservation is about 40 minutes, and with radiation therapy, it's about 1 hour, 1 hour 10. But in the end, it improves the understanding between surgeons and radiation oncologists in general, and that is beneficial also in cases where you do not radiate intraoperatively. Thank you very much for your interest in this talk, and I'm happy to answer your questions then during the webinar. Thank you very much.
Thank you, Professor Heil, for sharing your presentation. As you note, in the published literature, I know with spherical applicators, there's some limitations in the proximity of the tumor. So I'm glad to hear so far in your clinical experience, you're not seeing such limitations from an anatomical perspective for those patients that you think can qualify for this treatment. I think we have a number of questions, and we'll let Billy shoot those off.
Perhaps you can sort out those questions you want to have answered.
Sure.
Yeah, it looks like there's quite a few here, Derek. So we'll have to pick a few. Let's see.
Perhaps you can cover this one on DCIS at the margin.
Yeah, that's a good question. So you're absolutely right that DCIS at the margin is in all breast cancer patients, yes, often the case, often in about, I would say, in our cohort in Heidelberg, it's about 20% of the cases. But, and that is what I think you need to stress, is that for the IORT cohort, you should be quite strict on inclusion, on selection. You should, what is the inclusion, the most important inclusion criteria? You should be confident that it is a unifocal tumor in a well interpretable breast, so that the risk of extensive intraductal component, for example, is low. So with these inclusion criteria, you are able to really have a very, very low rate of unclear resection margins for DCIS or invasive tumor. In our cohort, it is below 3%. And this is not because we are good surgeons, it is because we really pick those patients perfectly suited for this kind of approach.
And I think another question is, as an oncoplastic surgeon, you might be in a good position to answer that. The question was, what's the clinical benefit of the IORT versus using, say, external partial breast irradiation in these patients?
If you do intraoperative radiation therapy in the larger tumors, you should be aware of what Professor Debus told you. When you do large volume arrangements during oncoplastic approaches, it is very important that you radiate the right breast position. And if you, I would say, rotate the upper outer quadrant to the lower inner quadrant, for example, when you do a post-operative percutaneous radiation therapy, you might not really know where the exact position is, so you can't do partial breast irradiation properly. But intraoperatively, you exactly know where the margins and where the directly surrounding tissue is. So you can position this region of interest in your focus, and then you have the tube and you radiate the right position. That is, from my perspective, the most important advantage of intraoperative approach.
Thank you. There's another question, Derek, at the end and Professor Heil, on what the incidence of necrosis of breast tissue from radiation therapy.
Yeah, that's a good question. And again, it is not only the radiation therapy, it is a combination of radiation therapy, breast tissue, if you have a very atrophic fatty tissue, and you do huge arrangements, huge glandular flaps, necrosis is more often the case. So that is another reason why we focus on small tumors with relatively low volume arrangements. And in this cohort, we don't see a problem, or we very, very seldom see problems in the long run for liponecrosis.
Great, thank you, Dr. Heil. We do have a few more questions, but I'm sorry, we have come to the end of our time. And so what we will do, for those of you who have attended today, we thank you very much for all of your questions. And we have them noted, and we will do our best. We will follow up with responses to those. So this concludes the webinar today, and I would like to thank our speakers for presenting these wonderful talks today, and thank you all for being here today. We appreciate that you took the time to participate in these presentations from Professor Debus and Professor Heil, and we hope that you'll be able to join us on some other upcoming webinars that we will be hosting in the near future. Thank you, and everybody have a great day and great evening. Bye-bye.